Cultural humility, getting to know the other. We already know what cultural risk is. We have begun a process of self-reflection in the cultural awareness model. Now, we are ready to meet the other, the patient. As was mentioned by Melanie Trevelyan, humility is a prerequisite in this process, as the physician abandons the role of expert to the patient, becoming the student of the patient with a conviction of the patient's potential to be full partner in the therapeutic alliance. In this model, you will discover that the patient cherishes a culture that might be different than yours. We will talk about traditional medicine as a body of knowledge that your patient might possess to maintain their health and treat their disease. In the context of care provision, the idea that one culture is superior to another should be avoided. Traditional medicine is defined by the World Health Organization as the knowledge, skills, and practices based on theories, beliefs, and experiences indigenous to different cultures, whether explicable or not, used in the maintenance of health as well in the prevention, diagnosis, improvement, or treatment of physical or mental illness. In developing countries, up to 80% of the population seek care in traditional medicine to solve their health needs. This fact has gained the attention of researchers, and there is an agreement on the need to approach this phenomenon with both respect and scientific rigor. Examples of this fact are the Alma-Ata Declaration and the World Health Organization strategies on traditional medicine. Zuluaga mentions three conditions that a body of knowledge must fulfill to be considered as traditional medicine. The first one is historical support, that is, a body of knowledge that has been transmitted between generations for hundreds or even thousands of years. The second one is the geographical or territorial support, that is, that body of knowledge must be linked to a particular geographical region, for example, Chinese traditional medicine in China or the Ayurveda in India. The last condition is the relationship between that body of knowledge and a traditional culture. The so-called complementary and alternative medicine are different than traditional medicine because they lack at least of one of the conditions mentioned. Let's briefly go over some thoughts about traditional medicine in Colombia. Zuluaga suggests 5 characteristics that different bodies of knowledge share to be considered traditional medicine in Colombia. The first one is the tripling inheritance, that is, traditional medicine in Colombia is built based on 3 different influences. A. Indigenous knowledge. B. Afro-American knowledge. And C. Traditional knowledge brought by the Europeans during colonization. The second one is the presence of traditional healthcare providers. This is comprised of traditional healers, traditional midwives, and traditional bone setters, all of them with particular knowledge and skills. The third characteristic is the presence of key concepts to explain health status and health interventions such as cold, hot, body cleaning, and purge. The last characteristic is the so-called cultural nosology, that is, the presence of a cultural taxonomy to classify and explain disease. This was just a brief introduction to some basic ideas about traditional medicine. You will find some documents attached to this model in case you wish to further explore the topic. We are now aware of the cultural differences that may be present in a routine medical appointment. On the one hand, there is the health professional loaded with concepts brought from the Western culture. On the other side, we have the patient with particular needs and expectations aligned with their traditional culture. As we discussed in the intro video, these cultural differences often lead to a care gap that may be harmful to patients. How can we address this cultural gap? You will get an idea after finishing the next model.